Welcome to Spine Conference. So today's discussion is going to be on positioning for spinal surgery during anesthesia. So this is a very relevant topic, and we haven't had any problems, but I think it's very important to go over. So as always, if anybody has any questions, just interrupt me. So the typical position for a spinal surgery when you start, obviously, is supine because you have to get an airway. And the only way you can get an airway really is supine position. So this is just sort of a starting point in surgery. And you see in this case, the arms are tucked to the side with sheets. And the best position for the hands, my opinion is thumb forwards, which is neutral. So this position, what position is the hand here? Right off the bat, this is not a good position. What is it? Pronated, yeah. So pronated puts the most stress on the ulnar nerve. So it's best to be neutral. And the other thing is I like to have the hands free because anesthesia has to get to it for IVs. Also, if you do a neuro exam, you have to examine the hand. Also for arterial line. What about X-rays? No, well, this is the anterior position. This is supine position. Yeah, we're just starting anterior, then we go posterior. Okay, so to gain access to the airway, you can see this. The neck has to be extended. You see how extended the neck is, and what can happen, not always, but what can happen is the anesthesiologist is focused on the airway, and rightly so because he has to insert the airway. But the problem is the patient has another coexisting problem, is a neck problem. So extension can cause a serious problem. Once in my first year in practice, there was a patient with ankylosing spondylitis who presented to the emergency room, and they thought she had an airway problem, and they broke her neck putting in the airway just by that extension because she was solidly fused. So it's something that the anesthesiologist, it may not be the first thing on their mind. They're worried about the airway. So why is extension? So this is just a typical cervical patient. There's pressure on the spinal cord, and any motion of the neck has the potential of causing a problem. Usually not, but it's possible. So the anesthesiologist has to be careful. So the reason why extension is bad for the cervical spine is you can see in this cartoon, in the flex position, the ligamentum flavum is tight. But as you extend, the ligamentum flavum buckles. Can you guys see that on the right? So, and when the ligamentum flavum buckles, because the bones in the back are getting closer to each other, so the ligament that connects the two bones buckles because the air is getting closer. That pushes in on the spinal cord, and it can cause worsening stenosis. So, here's an example of MRI. On the right, the patient's flexed, and you can see the ligamentum flavum. That black line is straight, and the middle picture is extended. Actually, I think the middle picture is neutral, and the one on the left is extended. You can see as a patient gets more extended, the ligamentum flavum buckles, and it pushes in to the spinal canal. See, that when you see that, you understand it. So extension increases cervical stenosis. Now, intraoperatively, for levels of the spinal cord, I always get neuromonitoring, and basically, does everyone know what neuromonitoring is? There's little needles, head, scalp, arms, legs, runs an electrical current up and down from the brain to the toes and fingertips, and they measure. They send out a signal, and then they measure the receipt of the signal, and they show that the spinal cord's intact. So I always get baselines in cervical cases, just so that I know that my positioning didn't cause a problem. Because if my position caused a problem, I got to change the positioning if I can. They can do EMGs, yeah, they can do EMGs. But I think what they typically do is they send a signal. I mostly do sensories because they're the least disruptive to the operating room, because motors can be disruptive. EMGs are not a big deal. They just measure if I stimulate something. But the sensories, they stimulate lower down, and they measure the receipt in the brain. It's kind of amazing, actually, if you think about it. They can sense a problem with the spinal cord. So A huge development has been the glide scope. Does everybody know what the glide scope is? So it's basically, it's nothing special really. It's just a scope attached to a device that you intubate with, kind of like a knee scope. But whoever put this together was genius, because now airways are so easy to manage. It used to be like maybe 10 years ago, they didn't have this, and for a difficult airway, it was a disaster. It was like, because the thing about, I don't know if you know about airways, is that you only get a couple shots, and then the airway gets inflamed and swollen, and then it's very difficult to intubate. So this, they get it almost always in the first shot. So it's been a huge benefit to mankind. I don't own any stock in the company, but I wish I did. But they also have these things in the ambulances. So I'm pretty sure in Howard County they have them in ambulances, and they've been studying it. So the guys on the, that go to the car accidents, they can stick airways in, which is great. So I just want to go over a couple of things about positioning. So this guy is just basically supine. And there's a couple things. First is, most people don't look like that. Most people have slight kyphosis to their necks. And that's I mean, we're not talking about 18-year-old people. We're talking about adults who have disease. They have slight kyphosis. And some people can't even get like that, can't even lay flat like that. I'll show you what I mean. But this is like a standard supine position for like an ACDF. And you can see this is a standard position. If you want to get to the typical areas, C5, C6, C6, C7, that's the angle that you have to approach the C. Can you see the angle? Now, you can imagine me as a surgeon and my assistant, we don't like to have our heads cocked like that during the operation because it's uncomfortable. And we have to do it for hours at a time. So the typical thing to do is you extend the neck of the patient, or you do T-Berg, Trendelenburg, where you put the head down to the table. And that way it's a straight shot down. It's a lot easier for us and we can do it. So does that make sense? Go down. We're going over spinal positioning and surgery. So this is a very common problem in cervical surgery. So how do we get the extension? I mean, what I usually, this is just what I do. I'm sure there's other ways and tricks or whatnot, but I usually put a roll behind the scapula, and that gains more extension. I don't know if you can tell, but I'm more extended there. We're talking about extension of the cervical spine just to gain access, because typically, this is a typical man here, Alan, and then the angle's difficult for the surgeon, so we extend it. But by extending the neck, that can cause problems too. And also T-Berg, we'll go through Trendelenburg position. T-Berg can cause problems in the spine. So this is, I just put this out there. Some people, when you put them to sleep, they look like this. And if to the uninitiated, you're like, why is the patient doing a sit-up? They're not doing a sit-up. That's where they're fused. So they have cervical kyphosis and they're fused in that position. And that puts a lot of stress on the spine. So they can fracture their spines. So what happened in the case of the woman I told you with ankylosing spondylitis, she came to the ER like that and she was losing her airway. Well, the anesthesiologist extended the airway. I'll show you what, if you see it, it makes more sense. The anesthesiologist extended the neck to get the tube in, and as a result, they had a fracture of the neck. So this is always like a serious problem in the cervical spine that you have to, in the diseased cervical spine, you have to consider. The other thing is we have to do something with the arms during the operation. So we tuck the arms. And it's best to tuck the arms underneath the patient, because if you tuck it under the table, it can cause undue pressure. So that's why I tuck them like we tuck them. The one on the right is correct. The one on the left is not. Okay. So any questions about the supine position in the cervical surgery, ACDFs? Okay. Next is the prone position. So the prone position is the more typical position, because usually we approach the spine posteriorly on the backside. There's a couple things that are serious problems with the prone position. We'll go over all of them. Now, in the old days, we had mostly just gel rolls, and that was our positioning. And we would apply the gel rolls either transversely or longitudinally. This is transversely. And the purpose of the gel rolls are, first of all, so people don't get pressure sores in the bony areas. So the bony areas are the iliac crest and the top of the chest. So the gel rolls kind of give a soft landing to the whole body while they're asleep. And also, more importantly, the gel rolls are good for breathing. The lungs can expand easily, and also it avoids pressure on the IVC or in the inferior vena cava. So most people here know about pregnancy because we're all adults. And when a woman's pregnant, the baby, when it's big, can push on the inferior vena cava. And that's why either if you guys are pregnant or your wives are pregnant, when the woman's like 8, 9 months and they're laying flat on their back, it's very, very uncomfortable because the baby's pushing on the inferior vena cava. And so that's why pregnant women sleep on their sides usually, and it's more comfortable. Now, why is it a problem to push on the inferior vena cava? Is that it distends, for me, among other things, for me, it engorges Batson's plexus. So Batson's plexus is the rich anastomosis of veins that is connected to the inferior vena cava. You see how the inferior vena cava there goes into the spine. And these epidural vessels go up and down the spine. So if you push on the inferior vena cava, it makes all the veins very big in the spine. And that's a problem with spine surgery because then these veins, we injure them when we do the surgery and they bleed a lot. So it's very important for us to have an unobstructed inferior vena cava like that during the surgery. So any questions about that? Inferior vena cava breathing? Okay. So this is just another cartoon showing that in the extended position of the spine, the ligamentum flavum buckles and causes stenosis. And when you flex, the ligamentum flavum is tight and it does not cause stenosis. Same thing in the cervical spine, same thing in the lumbar spine. So most of the spinal tables, when they first were created, they were created to make the spine flexed so that you can gain access to the lumbar spine. Now, we don't do it anymore because having the spine in a flexed position is very difficult and uncomfortable. And I'll show you how it evolved. And nobody really talks about this. I don't know why they don't talk about it, but as spine surgeons, we don't talk about it that much, that our tables have evolved. So let me tell you how the evolution. So in the super old days, there was just gel rolls. And then when I was in training, this is what we used, the Wilson frame. You guys know the Wilson frame, right? Everybody knows it. Have you guys seen it? You crank it up, and it accomplishes many of the things that we like. You can see the inferior vena cava is not being compressed because if you have a big belly, it just lays in the middle. It's like two sleds actually. It's not, that thing's not continuous. It looks like a double rainbow, and the middle is hollow. Can you guys imagine that? So it's like having two rainbows, and the middle is hollow, so the belly is free. And the chest can expand, and also you see it gives lordosis, so we can gain access to the spine. Now, it's not great for the hands, and it's not really great for the head. Now then in 1980, there was a company called Orthopedic Systems Incorporated that was from Hayward, California. They came out with this table called the Andrews table. Did you guys ever know the Andrews table? Okay, so I used the Andrews table in fellowship. Oh my God, I really hated it. It was very uncomfortable for the patient. It was really hard. It was really hard to figure out. It was kind of a trial of fire for the fellows that they have to understand how the table works. And oh my God. And the other thing is that it can cause a lot of problems. Like anesthesia didn't understand it. And then like you can get problems from this table. You can see the knees can get pressure sores for long cases. And I mean, I know of a complication, not of mine, but of a colleague. They had tibial compartment syndromes from pressure on the legs from an Andrews frame. So it was a difficult table to use, for me anyway. Does anybody else know about the Andrews? And that's the person who invented the Andrews table. Interestingly, he was a very successful spinal surgeon in San Francisco, and he died a couple of years ago from the effects of Parkinson's disease. So he was spine surgeon from San Francisco. Okay, now this is the table I use, and I think most people use, is the Jackson table, and that's Roger Jackson, who's from North Kansas City, Missouri. He developed it with OSI in the late 1980s. And it's a multi-purpose table for trauma as well. And you can see the belly's free. The one thing it doesn't have is no flexion of the spine. But it's really hard to get flexion of the spine. And you can see there's a place for the face, and you can also attach tongs to the head, and it goes through a wire through the table. So that's the old Jackson. And the other thing that the Jackson can do is you can make a sandwich out of the patient. You can put two frames on top of each other and flip the patient. So the theory is if you have to turn the patient, like first do a posterior surgery and then anterior surgery, you can just do it through this table. Now, practically, it is a real pain in the rear end to do this. And you're always worried the patient's going to fall between the cracks. Personally, I just think just get another stretcher. We'll just turn it old school. You don't save that much time, and you can watch the patient. I don't know. I don't like it. I just say bring the stretcher. I'm not doing this whole thing, and everyone's scared. And it's like it's a big mess. It's like it's a fire drill. Just get the stretcher in here. We'll turn. We'll be careful with the patient. So I don't do this. I don't use the flip. Well, we're shock trauma is like the real big thing that we're using the table to flip the patient. Now in my old age, I'm more practical. I'm like, just get the stretcher in here. It just makes it a lot easier. I say old age should make Alan laugh. So so now this is the newer Jackson table. In 2002, the company Orthopedic Systems Incorporated was bought by a Japanese company, Mizuho, in Tokyo, Japan. They own it now. And the new Jackson table is better. I think that's the second one. This is the one that we have. We have the third generation. There's also a fourth generation that's interesting. But ours, you can see it bends, so you can flex the spine. There's a bend there where that pillow is. And you see it on the top where the chest is, to hold the chest is like a C now. So it kind of cups the patient, and it's great for big patients because they don't sort of fall off the table. Like the old one, you could potentially fall off the table. You see that? You could literally roll off the table. From a normal sized person, it's not going to happen. But for a big person, it could easily happen because big people have a more round shape, and they could just keep rolling off the table when you roll them back and forth. So the C, I think, works great. What do you think? And you can see where the pads go over the iliac crest. And that has the hole for the belly, and you can flex if you want. So this is just so anybody doesn't know, this is the Trendelenburg position, like head down, and this is the reverse Trendelenburg. And we'll go over this, but sometimes, just in general, I always try to do reverse Trendelenburg. Actually, that's spelled wrong. Sorry about that. This is somebody else's slide. He spelled Trendelenburg wrong. Reverse Trendelenburg is a lot better than Trendelenburg. And the reason, and I'll tell you why. So when you do a prone position, it's also called the Superman position or the prone surrender position. So this is me on the table. This is our typical positioning, and the arms have boards to hold it. So there's a couple things. First is the shoulders should be less than 90 degrees, and optimally the elbows are not flexed, but it's hard to do that practically. And I'll get into that as well. And you can see the C right under my arm, my axilla there. You can see the C is holding my body. So if you rotate, I won't fly off the table. So what complications can happen? First, I wanted to talk about is corneal abrasion. Has anybody here had a corneal abrasion? Do they hurt? They hurt like crazy. Have you had one? I'm the only person here who's had a corneal abrasion. They hurt like crazy. They're so painful. And if you do a spinal surgery and they get a corneal abrasion, that's all they talk about. They don't even feel the spine. Yeah, that's all they talk about, right? It's my eye hurts, my eye hurts, my eye hurts. So it's really painful. Yeah, they're miserable. So first thing is to protect the eyes so you don't get a corneal abrasion. So our anesthesia colleagues do that, and they usually there's different ways to do it. You can either tape them shut. You can use those goggles, which I kind of like the goggles because I feel like there's no way you can injure the eye with those things. Most people do the thing on the left. They use left bottom. They use tape and that square pillow. And we also have that mask type foam contraption with a mirror, so the anesthesia can watch the airway in the eyes, which a lot of anesthesists really like that too. So these are the different options. So if you properly tape the eye shut, they should not get a corneal abrasion. But apparently anesthesia says they open their eyes during surgery. I don't know how they still get them, but they still get them. So the other thing in the prone position, and especially when I operate on the neck, I use a Gardner-Wells tongs. This is the Gardner-Wells tongs. It goes into the skull, and it's a great way to control the head and neck. So this is a Gardner-Wells tongs in a supine position, But just imagine that the patient's prone. It's the same thing. And I always use it because I feel it's the safest way to control the head and neck. So there's no chance that the neck will move during the operation to protect the eyes, protect the nose, protect the face, protect the airway, and I think it's worth it. So I think Gardner-Wells tongs, I put it on to protect the face basically during these surgeries. So next we're going to talk about palsies. This is like hand palsy. So in the prone position, you can get a palsy of a nerve, and the way you get a palsy of the nerve is either from direct pressure or from stretching in a abnormal position. And this is where the brachial plexus is. It's basically between the cervical spine and the shoulder. And I haven't had a lot of I haven't had a brachial plexus palsy in probably 10 years, but I did before that. They're always big men, like very big men with a lot of muscles and long cases. So I think those big muscle strapped men are stiff. They naturally they're not very mobile. And then you mobilize them in the Superman position, which is not physiologic. I mean, almost nobody walks around like. Actually, right now, when I put my arm, I mean, I'm not Hulk Hogan or anything, but I do. I'm kind of low. I would say I'm not small, but I'm not huge. But when I do this, it hurts. Like I don't feel. Tony, why don't you do that? Does that hurt? It doesn't feel good, right? So let's just say someone tells you to do this for like 4 hours. It can cause a problem. So it's usually in like big men that they get this. And almost always the palsy goes away. The other one is the cubital tunnel. So the ulnar nerve, which is the most common nerve palsy in spinal surgery, goes along the epicondyle of the humerus, and also there's a flexor retinaculum over the nerve, and this nerve can get compressed during the surgery. Ulnar nerve, the risk factors are basically people who have atherosclerosis risk factors like smokers, high blood pressure, diabetes, age. But also if you have hypovolemia or hypoxia, you can get ulnar nerve palsy. And usually it's numbness of the fifth and fourth finger. And you can also get a motor palsy, which is a problem. It's the interosity of the hands, and you have a hard time writing and doing fine things with your hand. So how can you protect it? Basically, the way to protect the ulnar nerve is supination and extension. So the tunnel is the least tight when you supinate it with the palm up and when you extend it. And it's worse if you flex it all the way, and it's worse if you pronate all the way. So you just try to avoid deep flexion and try to avoid pronation during the surgery. And that's basically the best place for the ulnar nerve. So the eye is another thing that get damaged in surgery. So people going through spinal surgery, it's possible that you could wake up blind. So, the thought of that is horrible. And so it's very, very rare, but you have to understand it so that it can never happen. So this is always in your mind. So most of it's from ischemia of the optic nerve. So basically all the input from the environment goes into the retina, and the retina takes it into the optic nerve. The optic nerve takes it into the brain. So the optic nerve has a blood vessel because it needs blood supply. And the biggest problem with the blindness from surgery is from ischemia of the optic nerve. So what causes ischemia? Well, decreased blood pressure can cause it, just like anything else, vascotone. But the most common problem is intraocular pressure. So the eye pressure can increase during spinal surgery, and we'll get into that. So these are statistics from a study of 93 cases of postoperative visual loss. So the incidence is very low, less than 1 in 500. You can get it from direct trauma, but it's usually from ischemic optic neuropathy. You can also get it from central artery occlusion from like trauma, direct trauma. But usually, it's very unusual. Most anesthesiologists and surgeons are very careful about positioning. So who gets this? It's usually men. I don't know why it's usually men. Most of them are long surgeries, like over 6 hours, 84% over 6 hours, and the median time was 9.8 hours, which is a really long case. So, and there's blood loss more than a liter, and it can be a delayed onset. People can have the problem 15 hours post-op. So the most common problem is increased intraocular pressure, and increased intraocular pressure is most common in T-Berg. So I'll just get into this. So this is just one more reason, like as a spine surgeon, me personally, I get very uncomfortable after 6 hours and 1 liter. So at 6 hour point and 1 liter, I start thinking maybe it's time to quit. The problem is it's really hard to quit as a surgeon, and it's because of personality problem. Like, and the reason is nobody talks about this. The reason is we're really goal-oriented people, and we don't stop fighting. You know, it's like spine surgeons are usually fighters, and they don't want to give up. And it's very hard for you as a human being to say, I got to stop here. I got to punt. It's 4th down and 1 inch, but I got to punt. And it's very hard to punt sometimes. You know, everyone's like, got to go for it. So that's what I think is sometimes you have to use some common sense. So what happens is you have increased pressure in your eye. The venous pressure increases. The arterial flow keeps going in, and the pressure builds up, just like in a compartment. So when you see this guy, it's obvious if they put you in this T-bird position, you can imagine what your face will feel like. It'll feel really swollen and uncomfortable. So the Trendelenburg position significantly increases intraocular pressure. And so for every minute, it's 0.05 millimeters in that study. And this is just another study. The bottom one is flat, and the top one is pressure and T-bird, and the bottom's time. So you can see as time goes on, the pressure increases. And I have a theory why. So you may say to yourself, why would anybody want T-bird? Like, it's crazy. Like, why would they do it, right? It doesn't make any sense. It's illogical. I just thought about this today, actually, when I was driving in. I think I know why. It's because most people are slightly kyphotic. Most necks are kyphotic. And if you look at me, like I'm kyphotic there, my neck's a little kyphotic there. And you can see, like, to put my eyeball at the same level of my heart, it would be a big angle for the table, upward angle. And then it's uncomfortable for the surgeon. So basically surgeons, they can't do the surgery with the upright position. So it always has to be a little bit down. You see that? Because then the surgeon's neck has to be crooked the whole time. And nobody can operate at a 30-degree angle for like 6 hours. So I think it's just the nature of spinal surgery that they're always slightly T-bird. And the other injury you can have is central retinal artery occlusion, mostly from positioning and external pressure on the globe. So who gets blindness from spine surgery? All of the risks are the same risks as atherosclerosis, which are all here: age, men, family history, hyperlipidemia, high blood pressure, smoking, diabetes. So the same risk factors that go into atherosclerosis go into retinal artery occlusion and retinal artery problems with surgery. So any questions about that? So the other way I think of it in my mind is when patients are on the table, it's like they're passed out drunk. I mean, so you can imagine this guy, if he stays there for 6 hours, when he wakes up, he's got serious problems. He's got pressure ulcers, and the other thing that he can get is rhabdomyolysis. So just from the pressure, especially big guys, big people, just from the pressure laying flat, the muscle dies, the proteins from the muscle go into the bloodstream, they get peed out by the kidneys, and then your urine looks like Coca-Cola from all the protein. So patients can get rhabdomyolysis from long spinal surgeries as well. And then the last thing I'll talk about is pressure on the face, which is very important. That's me, and that's a pan in my kitchen right up against my face. So the patient's prone. So you can look at the portions of the face that can be injured, or the forehead, the nose especially, and the chin. And everybody is really good about the nose because it's so obvious, but the forehead and the chin get pressured too. So these are things that we have to look at. All right, that's it for today. So any questions about positioning and spinal surgery? Yes.
What about, I can't remember what they're called, but in your patient in an ICU bed, they have a mattress that ripples.
Yeah.
You don't use anything like that? Because what we're seeing here is a constant position, a constant pressure on a particular area. If you had inflatable support things.
I've never thought of that. I don't know. I don't know why people haven't designed that.
Mm-hmm.
Usually, I think the answer is usually that's not a problem. Like the positioning is where the body meets the table. The cushions are so good, it's not a problem. So I don't think it'll change anything.
Mm-hmm.
So if you look at our the table we use, it's very rare that we get a position like this. Well, you can't see the foam. Here's our table. It's pretty good. We almost never get a problem from where the body meets the table. It can. People do get hip pain from there.
Just with the
Yeah, I think the answer though is don't do long surgeries. Period. And that's when you start having problems. Try to keep the surgeries less than 6 hours.
Now, does the anesthesiologist treat the patient and then you roll them over?
Yes.
That can be quite tricky, keeping this in the position.
It's usually not a problem. It's a problem if the anesthesiologist is irresponsible or not paying attention, which, trust me, it happens. So, as a spine surgeon, I always tell people, look, you have to be very careful with the neck because it's very stenotic, and they look at me like I'm crazy, but people do forget. So, since I'm the one that's ultimately responsible, I feel compelled to have to say it. Usually, it's not a problem. So,
how much is a bed like this cost?
Brian, do you know? You're the money man. No, I think it's $100,000. Yeah, I think $100,000. They're pretty expensive, and then to fix them are expensive too. There's a lot of upgrades; those are expensive too. They get the hospitals in the aftermarket sales, like Caterpillar. So you sell them this big tractor, but then you constantly have to fix the tractor. It costs money.
Well, they sell you a service package, and if the hospital's not smart enough to take the service package, then bill them for every service.
Yes.
There's so many people, like, I can totally understand if you're doing lumbar surgery, having pain
Across the chest, yeah.
You're laying on that.
Yeah.
What about, because I still have had some, like,
A lot of people.
say, is that just because of the surgery that you're doing?
The chest hurts? No, I think ACDFs, that's just there's no pressure on the chest. That's just maybe referred pain from the spine. Maybe. Back of the neck. Yeah.
Right. Well, yeah, it's not very many, but if they do say, I'm like, maybe the way that, I just think maybe the way they position.
No, the other thing I didn't talk about is women and breasts. It's like there's nothing you can do with women's breasts because they have to lay on them, and it's a problem, especially if they have large breasts. Is that there's pressure on the breasts, so there's no good solution for that. I think unless someone creates some kind of like cup system that you can interchange maybe for the spine tables. I mean that would make sense. It doesn't exist on the market. Well, yeah, you just have like like a bra. You have like a reverse cup for women with breasts. Just like they have in fencing, they have breastplates for men and they have breastplates for women. And the women ones are shaped for women, for their breasts. So if they don't do that for spine surgery, I mean, they probably should. Yeah, sure. Men with breasts too. It's not that common. So what else? Any other questions? Positioning. All right. Thanks for coming, guys. Hope somebody learned something. I know I did.